Next speaker should be Dr. Imad Al-Shahwani. He is going to talk about a modification of Mيكولكز procedure and the surgical treatment of sigmoid colon volvulus. Welcome, Dr. Imad.
Thank you, Mr. Chairman. I am delighted to share my paper with colleague Egyptian surgeon in the 40th annual meeting of Egyptian Society of Surgeons. The title of my paper is Modification of Mيكولكز Procedure in the Surgical Treatment of Sigmoid Colon Volvulus. In the introduction, volvulus refers to torsion of a segment of alimentary tract, which often leads to bowel obstruction. The most common sites of volvulus are the sigmoid colon and cecum. So the presentation here is mechanical intestinal obstruction. What concerns us is the surgical modalities of treatment for sigmoid volvulus. First, we have resection of the involved segment of colon and the primary anastomosis. But here, it is advisable to do perioperative colonic lavage. Second is resection and double barrel colostomy. As you can see in this diagram, you can resect the involved segment of colon and do two openings in the abdominal wall, one for the fecal colostomy, the other for mucus fistula. The other option is resection and Hartmann procedure when the distal part of the colon or distal limb of the colon is short and cannot be brought to the abdominal wall without tension easily. So you have to do Hartmann procedure and close it and put marker on it so that you can find it when do restoration of the continuity of the colon. The fourth is resection and Mيكولكز procedure. What is Mيكولكز procedure? Mيكولكز procedure, it is a known procedure to be useful in the treatment of volvulus of the colon, obstructed colonic carcinoma, and localized diverticular disease. It must only be attempted if both limbs of the stoma can be brought to the skin. The goal of this procedure is that the tissue between the double-barreled tubes is crushed and joined using side-to-side stapler with subsequent straightforward colostomy closure at a later stage. The closure of such colostomy will be extraperitoneal. And you can see this diagram will show you the Mيكولكز procedure. It is the resection of the affected involved colon and bringing both proximal and distal limbs of the colon to the skin and suturing both adjacent loops. The objective of our study, we present here a modification of the classical Mيكولكز procedure in the emergency surgical treatment of sigmoid volvulus, and to throw lights on the advantages of this modification among other surgical approaches. Methods. The design of our study was prospective. The setting in Al-Kindi Teaching Hospital, Baghdad, Iraq. It takes about 3 years. The modification consists of fashioning the colostomy by suturing the adjacent mucosa of the two limbs, as you can see it here, of the two limbs using interrupted absorbable suture, and to the surrounding skin, the lower diagram, you can see it, without placing suture in between the deepest approximated limbs. This is our method. The closure of colostomy in this modification, of course, after 6 weeks, will be similar to that of loop colostomy closure. And all colostomy closure in this modification was intraperitoneal. This diagram shows you the closure of the modification. First, we have mobilization of the stoma, and then simply closing the roof of the stoma. Results. 20 patients with sigmoid volvulus were included in this study. We applied modification of Paul Meikolix to 11 patients with sigmoid volvulus who required emergency surgical interference. Of them, there was a female 45.45% and 6 males 54.54%, with a median age of 58 years ranging 45 to 65 years. Only one patient, 9.09%, developed wound infection, and another patient, 9.09%, developed a mild degree of colostomy retraction. No mortality was recorded in our study. This table shows you the modalities of the treatment of sigmoid volvulus in our study. We were able to do endoscopic decompression in 3 patients, 15%, and in other 3 patients, the colon was not viable, was gangrenous, with a short distal limb, and we have to do Hartmann procedure, 15%. Resection and the primary anastomosis, we did that and was successful. 3 patients, 15%. The modified Paul Meikolix procedure we applied for 11 patients, 55%. So the total number is 20. When we come to the discussion, the modified Paul Meikolix procedure is easy to perform and easy to close technically. The advantages of this modification can be summarized by the following points. No perioperative colonic lavage is required in performing modified Paul Meikolix procedure, while it is an important step when performing resection and the primary anastomosis. Of course, this will shorten the duration of operation, which is a vital measure when operating on poor general condition patients. Second advantage, no stapling devices or interatomes are needed to crush tissue between the 2 limbs to join them together, as required in the classical Paul Meikolix colostomy. Third advantage, the closure of the modified Paul Meikolix colostomy is much easier, as the closure here is of the already formed loop colostomy than to close the ordinary double barrel colostomy or Hartmann procedure, and both of them, they need re-laparotomy. And finally, closure of the modified Paul Meikolix colostomy is intraperitoneal as compared to extraperitoneal closure as in the classical Paul Meikolix procedure. And as we know, intraperitoneal closure colostomies was reported to have significantly lower complications rate as wound infection and fecal fistula than extraperitoneal closure. In conclusion, we advise the use of modified Paul Meikolix procedure in the emergency surgery for sigmoid volvulus when the colon found to be viable and when both limbs of the stoma can be brought to the skin without tension. And thank you for your attention.
Any question from the floor? Thank you, Dr. Ahmed, and now we have to end the session.